Thank you, Declan. Good afternoon, everybody. It is afternoon, isn't it? Oh, almost. So, I wanted to talk about your picture of where we are in terms of the current state of the environment from an infrastructure and from a technology perspective in the Northwest Coast Datarock, what we see as the direction of travel over the next 3 years. And I also want to be, to the greatest extent possible, arc neutral here, although clearly we're focused on the Northwest Coast here today. There's a lot of areas of commonality and what we hope will become areas of valuable commonality between the four Datarocks in the Connected Health Cities project. I think Declan, my slides aren't quite up to. Oh, fair enough. I'll keep talking. Oh, you have to be a technologist to understand how purely garbage most technology actually is. It's a bit like being a cat owner cat owners will invariably hate cats more than anybody else could, and technology is a similar sort of similar thing. Declan really hit the nail on the head at the top of the day today when he talked about just how exciting a time we are in and how exciting this particular project is. I mean, it almost feels like, and Declan and I have talked about this before, it feels almost like a perfect storm in terms of what our previous aspirations have been, and actually having both the operational framework as well as now funding to start to put some of this work into practice. It's not so very long ago, so many years ago, that certainly in my career, that use of the phrase "best of breed" was almost a dirty phrase, and one ventured away from discussing it. You know, it was a time of great monolithic systems in both GP clinical systems and electronic patient record systems. Still a lot of that around, and perhaps too much of that around. But we are actually reaching a point now where technologically, with cloud services in particular, where key innovative technologies will become much more readily available to commissioners, to service providers, and to the general population in a way that I think will make for a much more exciting and much more open and flexible future for us all. So, without further ado, just to quickly introduce myself, Andrew Michaelson. I'm Managing Director of a small company based in Liverpool called Care Innovation. I also work as part of that company's involvement in this project. I serve as a consultant to Ames Grid Services in the role of systems architect for the Northwest Coast Datarock. Which way do I want to point this? Oh, it doesn't matter. Okay, fine. Okay. I think it might. There we go. Okay, so I have one slide. I'm trying to outgrow bullets. Apparently, I used to do those to death, so I'm trying not to kill you all with PowerPoint. This is a very, very high-level map of where we are today with the ecosystem of the Northwest Coast Datarock. Now, one of the things that was really interesting, and when Declan first introduced me to the idea of this, what was then a bid in progress for the Northwest Coast Datarock, the thing that fascinated me was that I think he, of all people, had the vision from day one to realize that we had a wealth of assets on the ground here, both in terms of information sources and technology pieces and ecosystems that could be brought together to form a very strong platform to build this ARC project upon. In some respects, in the Northwest Coast, we're almost uniquely placed there. So whilst Greater Manchester has a real asset that they are building on the ground in terms of data well, which will bring a fine aggregation of information from a whole range of clinical sources and local authority sources into one repository. We've got a different picture, but I think an equally exciting picture, and possibly one that has more assets on the ground today versus where we need to be. That, however, does not mean that we don't have challenges. We have many. But just to give you an example, looking at the diagram here, what is all this mess that I present to you? On the left, you have basically the core ecosystems that make up the Northwest Coast health economy. So you've got iLinks, which is an agreement between signatories to a data sharing agreement under the umbrella of Informatics Merseyside and NHS Liverpool CCG. And there are, I believe, 11 NHS chief executives who signed up to that data sharing agreement. You've got Declan's baby, LPRES, the Lancashire Patient Record Exchange Service, which is is an operational system today. It's based upon great technology provided by people like Tiani and Virgin Media, who are sort of making possible what until fairly recently would have been seen by most as being purely aspirational. You've got the Healthy Wirral project, a really interesting piece of work being done there by health NHS partners in Wirral with Cerner. Cerner deploying a similar sort of a technology for integration to the one that Tiani and Virgin Media have used to underpin LPRES. And then you've got the Cheshire Care Record, which is underpinned by technology from a company called GraphNet. And Cheshire Care Record is a great asset on day one for the Datarock project because it actually provides us with a uniform single record of patients across Cheshire in one place where we can actually look to as an early source of information and also for modelling what the information set that comes into the ARC will look like. Cheshire, like LPRES, provides us with a good day one snapshot. So whilst you've heard speakers so far this morning talk about the first phase, or phase 0 if you like, pulling in information from HES and starting to apply some pretty sophisticated data science to that data set, the next step that we see from a technology perspective is looking to some of these existing assets and seeing how can we actually start to bring in information from those records, aggregate that into the centre, and actually start to mash that data up with data from HES and primary care and other sources. The idea here is that one of the other great assets that we have on the ground, one of the reasons why I was so excited to be engaged by Dr. Dennis Keogh and AIMS to work on this project is the AIMS Health Cloud project. So with the risk of sounding like giving a commercial pitch here, I think it's important to understand what's so important about the AIMS Health Cloud and why that's such a game changer in terms of the infrastructure of the Northwest Coast for health. Here you have, really for the first time, a connection between commercial cloud services, which many of us will be familiar with from the likes of Amazon Web Services or Microsoft Windows Azure, sitting on top of an N3 aggregator. That is a service that will more rapidly allow technologies to connect to organizations on the private NHS network. That's a very, very important point because after all, here we are talking about how to get health information and move that around and into a center and to aggregate that data. It's very important that we actually have a good means of both deploying technology and then getting information across that barrier between the NHS private network and potential other areas where data may need to be at rest or to be acted upon. The other great value of the health cloud, of course, and this actually is taking the logic of cloud, if you like, well, let's say the logic of cloud to the next level. Okay, so when Dennis Keogh and I first sat down and started talking about this health cloud concept, one of the things I said to him was, if you look at services like Amazon Web Services, or you look at Windows Azure, you'll realize that actually cloud is a lot more than just database space or compute space or storage of various kinds in a cloud service environment that you can buy and rent by the minute, which, yes, cloud is that. But actually, it's much more about the value-added services. So, for instance, if you're building a technology solution and you need a way to connect one piece of technology to another, that can be rented as a service from a cloud operator. If you want to have a good data analytics and visualization package, that can probably be rented as a cloud resource by the minute from a cloud operator. Now, if you transpose that into the healthcare environment, what really matters in healthcare? Well, job one is interoperability. It's actually the ability to connect health systems to each other, to be able to share information electronically in ways that have been up until now difficult and in some cases not even possible, but also to be able to then integrate semantically as well as mechanically. So in other words, get information from point A to point B and actually have it mean the same thing at both ends of the pipe. And whether that is around normalizing different clinical coding schemes between different systems, say between read codes, SNOMED, CT coding systems, or whether it's about normalizing representations of patient consent. So, Mrs. Smith over here in Liverpool consents for her information to be shared with the Datarock for the following purposes or with other partners for following purposes. How do we know that the system where that information will then be moved to actually understands what Mrs. Smith's consent means and will then respect that consent? That's a whole area of semantic interoperability that's going to be critical to getting this project right. Another key part of this then is the actual data warehousing in the center of it. So we're very fortunate in the Northwest Coast, and particularly within the Ames Cloud, to have a strong partnership with Dr. David Stable. So for those of you who don't know who David is, he was one of the original founders of EMIS, and has since gone on to put a large amount of money, of his own personal money, into a charitable trust called the Endeavor Trust. And the idea of Endeavor is to develop interoperability as open source for healthcare, and for that, within, I think, 4 years, to become the property of the NHS. So it's really a great gift that he's giving back to the health economy, and we're very fortunate that this is the first instances of this are being stood up and are running as we speak within the Ames Health Cloud. So again, a key part of this, and there's a lot of conversation going on between some of the partners, like David Stables, like the folks at Tiani and at Virgin Media, to really take the best of each of those approaches and turn it into something really quite powerful and special. What David realized early on was that interoperability, in practical terms, had to mean more than just moving documents or pieces of information from point A to point B. That's very important, and he's put a lot of thought, and his team put a lot of thought into the heavy lifting of information at scale. But then also, what do you do with that information? Where do you actually put that information? How do you then present it in a way that will be useful to people? You know, in general terms, how do you warehouse that data? Now, within the Datarock project, within the Northwest Coast, we've got an interesting challenge. A lot of interesting challenges, but one that sort of sprung to mind to me early on in this process was actually, what do you do with the data when you've actually got it from these various sources? And I'm pretty sure the folks in Greater Manchester and Datawell are already wrestling with, or will be wrestling with this same question. Because the fact that we get information, can get information from multiple different ecosystems may put us on a different footing potentially from a different project like Datawell. But actually, once you've got the data into the center, you've got the same sort of challenges. So I've talked about consent, issues of identity and so forth. But also, how do you represent that data back to people like the folks at Hartree, to the clinicians and others in a way that's useful? Does it make sense to actually aggregate all of this data into one great lump, if you like, normalize this into a set of coding standards or a set of representation standards in one data source and say, right, now you can pull data from this one place and you can do things with it? Or does it actually make sense to actually pull data in and create a library of separate data sources within the center as well? So the idea being then that Hartree and others can simply rack up to the Northwest Coast Datarock and say, right, I want the following information sets from your menu, please. I want one of these, two of these, and three of these. Put them together, and then act on the data that way. So these are all, in simple terms, these are all key questions that we will be working towards. The challenge to somebody like me is actually how to create an environment, how to create a set of infrastructure that is capable of providing these options and supporting the evolution of these developments as they move forward. Another key part of this is what we've identified here as an API plugin layer. The idea that a gentleman earlier on asked a question of actually how we're going to open up the Datarock to the broader community. And the key answer to that is a piece of work that's now being done by a working group that's been constituted under the Connected Health Cities Technology Steering Group. And this working group, chaired by myself, Declan, and David Stables, it's an interesting three-way chair we have, is looking specifically at how to develop an open standard for health app interoperability. The idea that you should actually have a plugin layer, not just within the Datarock, though this is obviously a good place to model it, but a plugin layer that would allow any health app that's compliant to work in much the same way that Google apps do. So if you open up a web browser, you go to Google homepage, there's an app for everything you could think of, translate, maps, images, you name it, but they all work in the same framework without you having to sign into different places and without you having to do different things to make them all work in a uniform way. That's what we're hoping to build up as part of that, as part of this project, so that yes, health apps, health and care apps actually, from various different parts of, in this case, the pathways relating to alcohol and unplanned admission, whether these are apps used by clinicians, whether they are apps used by third sector organizations, or by patients themselves, or patients, family and friends, or carers. These are all potentially valuable sources of information, whether it be the actual data created within an app or the metadata about somebody's activity. And all that information should easily, with a good uniform approach, to a good open standard to interoperability, be able to be pulled into the Datarock as well and to add value to the data science and the clinical research. if you look at this beyond just the constraints, if you can call it constraints, of the initial plans for a learning health system, the obvious objective, the obvious direction of travel here is to actually create a new way of operationalizing healthcare and the delivery of healthcare across the northwest coast in this particular case, potentially a network of hubs or arcs across the entire country. And in that respect, the increasing engagement with industry and engagement through the next generation of technologies, be they mobile apps or whatever they may be, will be an increasingly important part of what we do, is to make sure that this system is opened up for two-way traffic in a way that will add value to both the patient experience and, of course, to the delivery of care as well. So there are a number of different things I'm sure I could say, but I would probably rob you all of the will to live, so perhaps it would be probably wise for me to draw a line at this point.
It's always a hard slot. So stay on.